event with Maidin. So Maidin has joined it with us, and I think Maidin also will give opening speech to this event. So for everyone, thank you so much for your joining and also participate in this event, and I will hope you will get a good insight and also a new perspective about the research method, because you know that Ting Ting and also Dr. Ida will give a good listen to us about how to plan, how to implement about the unconventional approach in the health research. Dr. Ida is our supervisor when I did my PhD in Netherlands, and also Ting Ting is my colleague when I did the same thing in Netherlands. So before we start this event, please, my dean, Dr. Budiono, the judge is closed, so you can give opening speech to this event. The floor is yours. Thank you.
Thank you, Pak Yudi Darmawan, PhD. Thank you very much for this opportunity. Bismillahirrahmanirrahim. Dear Dr. Ida J. Corvus and Ting Ting Siu, PhD from Erasmus Medical Center of Medical Center Rotterdam, the Netherlands, and moderator Pak Yudi Darmawan, PhD, and our colleagues, lecturer, and all of the participants from doctoral program of public health, especially for our student. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillah, Rabbil Alamin. We know that the field of public health is dedicated to protecting and improving the health of population or community, especially by focusing on disease prevention and health promotion and ensuring access to care for entire communities rather than individual patient, of course. And it encompasses a wide range of activities like disease surveillance, health education, and developing policies to promote healthy lifestyles. For example, control infectious diseases and also control communicable diseases and ensure environmental safety. The characteristics of public health are first, focus on population or community. Public health expert will work with the health of the whole community, which can be as small as a neighborhood, for example, or as large as entire country. Second, emphasize preventing overtreatment. Primary goal is to prevent diseases and injuries from happening in the first place. And the third, the characteristic of public health interdisciplinary in nature. It draws on a variety of disciplines, including epidemiology, for example, biostatistics, social sciences, environmental health, and also health policy. And then requires good organizational efforts. We know that public health relies on organized efforts from society to achieve its goals. And this can include government agencies, community organizations, and other groups working together, or we call stakeholders. We know that the field of public health is a scientific field with a fairly broad scope. So that conducting research requires a certain approach. So unconventional approaches are needed in conducting research and or intervention in the field of public health. Thus, the theme to this lecture is very appropriate, I think, eh, with the title An Unconventional Approach in Public Health Research. Lesson learned from a research approach in the Netherlands and the possibility to implement it in Indonesia. And what does this approach looks like? And can it be applied in Indonesia? And what considerations are needed for its adaptation in Indonesia? Dr. Ida and also Ting Su, I think they are experts with excellent knowledge and also experience in the fields of the approach or the method in public health research. They will uh, explain briefly this in detail because they have many experiences or lessons learned uh, from their country and will share in this session. I hope you all pay attention to and are active in discussing this because it will lead you to a different perspective and finally enjoy the lectures. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Budiono, for your opening speech. It's very insightful to us and to give a motivation to us to learn about how to make unconventional method research, especially in health research. Thank you very much, Dr. Budiono, as our Dean of Faculty of Public Health, Diponegoro University. And now we will continue to the main event in this afternoon, in this morning in Netherlands, of course. And we have two speakers today. First, Dr. Ida Sihovage. Dr. Ida is Associate Professor of Decision Making and Quality of Life. Is an economist and also epidemiologist by training and has expertise considering patient and public involvement in research and teaching. Dr. Ida also co-principal investigator on European Union project on decision support tool on oncology, combining data science, design research, and medical and social science. This project is called 4D Picture with Judith Reason of is right, Dr. Ida? And other project, Dr. Ida also lead focus on shared decision making and the evaluation of e-health application. Also co-chair the EAPC task force on advanced care planning and the one on advanced care planning and dementia. And as I said previously, Dr. Ida is my supervisor when I did my PhD program in Erasmus MC, and I'm lucky because I have a good supervisor who tells me about how to be a good researcher, and I still keep your message, your advice to me. Thank you, Dr. Ida. And also we have a second speaker, Ting Su. Ting Su is a postdoctoral research and also PhD candidate at Erasmus MC. Ting now work focus on engaging Chinese immigrant in the Netherlands through the use of gamification in palliative care. Ting Su also has a training in quantitative research method and work extensively with community-based approach. So now we will learn from Dr. Ida and also thinking about how to ingest, also how to plan or maybe implement about the unconventional research method, especially in heart research. And maybe from this season, we can do the same thing in Indonesia. So, Dr. Ida, anything so? The floor is yours.
Thank you, Dr. Judy. Terima kasih. So we are happy to share our screen, and I would like to say that if in case of questions, people could maybe use the chat. Is that okay for you, Dr. Judy? If people have a question for
Okay.
us.
So if any question, so the participant will give the question in the chat, or maybe they can raise hand to you.
Okay.
Okay.
Yeah. So I will share the screen. So we are happy to talk with you today about advanced care planning and an approach towards advanced care planning with which Ting Ting Azul has much experience. So we will be both presenting. I will start and will share with you what actually the concept of advanced care planning is, how it works, the issues with advanced care planning, and also some next steps to be considered. So, advanced care planning. What is it exactly? Advanced care planning is often considered something palliative. So, is it only meant for people who will die? Some of the insights in this lecture that I'm sharing with you, most of them are based on my research, but some of them are based on conversations with my mother. So this is my mother. She is now 93 years of age, and she has been talking with me over the years what approaching death means for her. And I asked her a few years ago, is it okay if I use her picture and share her thoughts with audiences? And then she said that is okay. So first insight is what happened when an uncle of mine died. My uncle, he was called Rieks, he passed away, and I talked about it with my mother. And I said to her, I didn't expect it. And she said right away, are there people you don't expect to die? Such people don't exist, or do they? So, of course, my mother is right. There are no people we don't expect to die. Everybody will die at some point. So, does it mean that advanced care planning is then for everybody? It could be. So, what is actually advanced care planning? There were many a few years ago. There were many definitions around, but also many points of view what the concept actually was. So the EAPC initiated a task force. EAPC means European Association for Palliative Care. They issued a task force. My colleague Judith Rietjens on the picture, she was the chair of the task force. I was the co-chair. And with a group of experts, we drafted a definition based on consensus. We used a Delphi process, which is often used if there is no clear, very hard evidence. So it's based on asking people for their opinion and working together towards a consensus. And this is the definition that resulted. It was published in the Lancet Oncology in 2017. And the definition has a few key points. So it enables individuals to define goals and preferences for future medical treatment and care. So it is focused at thinking about the future and what people may want. It's focused on discussing the goals and preferences with family and healthcare providers, and also to record and review these preferences if appropriate. So it is aimed at people with capacity. It is aimed at people who can make up their mind about it. And there is also a focus on the process. It's not a thing one does in one point in time, but it is a discussion with the family, healthcare providers over time, during which people can consider what is important for them, what do they consider important. Also, they are recommended, they could write down what they want, but it's not considered a necessity. Also, Rebecca Sudore, an expert in advanced care planning, published a definition around that same time, and these definitions are quite similar. Then people with dementia and people taking care of people with dementia said, so the definition of 2017, it's focused at people with capacity, but what if someone doesn't have capacity? So there was another task force, and again initiated by the European Association of Palliative Care. This one was chaired by Jenny van der Steen. Again, I was a co-chair, and with a new pool of experts, we looked at the process and what it looks like if someone has dementia. And this is the resulting definition. So again, it is a process of communication, but the person with dementia has a role, but also the family and the healthcare team. And the idea is that even if someone cannot participate or make their own decisions, the process of advanced care planning can continue. So people can continue to wonder, what is it that someone wants, that this person would have wanted based on what we know about that person, about their preferences, and how can we make sure that the care that is provided to someone is in line with the preferences of the person. This entire movement of having advanced care planning came about since sometimes it occurs that somebody is very seriously ill, cannot make decisions for themselves, and others are wondering, what is the best thing to do? What should we do if we want to make decisions that are in line with someone, what someone would have liked? And if you haven't discussed it beforehand, it's really difficult to then make decisions. For instance, about resuscitation, yes or no? Should we do everything possible to keep the person alive, or should we aim for palliative care? And so that's really difficult if we haven't discussed it. And therefore, advanced care planning is a process in which it is recommended to think about these things and to communicate about future care and treatment preferences. And also, if someone has dementia, maybe in the early stages, it's not impossible. It's really possible to talk about what the person wants. So this was a really, I will share some insights with you from this process. We in this figure we show how we think the process looks like if someone has dementia. So you see a number of groups involved. The person with dementia has a role, there is a part of the family, and there is also a part that healthcare providers play. On the x-axis, you see the decline of the mental capacity of the person, and that usually becomes bigger, more and more decline of the person over time, and then the extent to which they can play an active part in the process, that will then slow, that will then change over time, and it will slow for the person with dementia, but the family will likely have a large role overall, and healthcare professionals may have a bigger and bigger role over time. So we started with a very simple picture, but over time it became much more complicated and detailed. We had very many versions, 41 versions. We had 3 rounds of the panel, and this is the result. In this process of drafting definitions, we based it on the literature, and we included people in a panel, but these publications and panel members originated quite often from high-income countries. So a number of people from Asia, they said, we would like to have another round of this definition process, and then focus at what it might look like in Asia. So this has been published in Palliative Medicine earlier this year. Masanori Mori, he is from Japan. He's the first author. Indonesian people were also involved in this process, including Dia Martina, you know her, Dr. Judy. She was involved in the process, and this is then the definition. Again, it's really similar and very much similarities with the one that was published 8 years ago in Lancet Oncology. But this one, as you may see, it is a process, but it is a very key thing that the family has a role. It is discussed with family and other closely related persons. That's a new key domain, a person-centered and family-based approach. So let's focus at the individual. And it facilitates the involvement of the family. So the family can support the engagement of the individual in the advanced care planning, and also taking care that the best interest of that person is taken into account in the process of shared decision making. So how does it work? Well, again, I talked about it with my mother, and she said it's really difficult to talk with a doctor about a treatment you want. You are afraid that they will say something like, get lost, if you speak up your mind. So it might be difficult, but how does it work, and does it have an effect? We conducted a trial in the Netherlands and also in Belgium, United Kingdom, Denmark, Italy, and Slovenia. And we coordinated this study in Erasmus MC in Rotterdam with 6 countries, as I just said, and we had a cluster randomized trial. So hospitals were randomized and either had an intervention or in a control arm, and we included more than 1,000 patients. These people all had advanced lung or colorectal cancer. And in the intervention hospital, they were offered advanced care planning. So they were offered conversations about their preferences for care and treatment by trained facilitators. They were also invited to have their family members involved. And in the control arm, care was as usual. So what did we find? We found that more people completed a form. Such a form is called an advance directive. And in such a form, people can indicate their preferences. So for instance, if there is no more hope for me to be cured, I like to do everything possible to prolong my life. Or they could have other preferences. What did we see? More of such forms were completed in the intervention arm, but that's not so strange since the intervention was aimed at having such forms completed. But we actually also wanted to have an effect that people would feel better. So for instance, better quality of life, or better coping with their disease, or maybe better shared decision making, or maybe other types of care being used. But none of these changed. So there was no significant impact on quality of life, on coping, on shared decision making, on the use of care. We did see that people in the intervention arm more often had specialist palliative care. So they may have become aware of their situation more and more willing to to ask for help of specialist palliative care. So we thought maybe this was not the population that would have benefited most, and we thought maybe fragile people have more benefit of advanced care planning, since with these people maybe there are more decisions to be made about the treatment they will receive. So we aim to conduct a pilot study including fragile people. And what are fragile people? These are people in our study who have many medication, who are often in the hospital, who are often maybe in the ER, emergency department, because they have things that don't go right in their life. And we thought these may benefit from having discussions about care and what they want. But it was very difficult to include people in the study. So it seemed that advanced care planning was not appealing to these people, and maybe they have too many things on their minds. Another important topic in advanced care planning is timing, when to offer advanced care planning to people. And Ting Ting will share some of the insights about it.
Hi, I will continue sharing the study we conducted about the timing of advanced care planning in patients with advanced cancer under the ACTION trial. This timing in advanced care planning often brings us a question: when do we conduct advanced care planning? What is the ideal timing to initiate the conversation with patients, especially when they start having serious illness, and when their serious illness is progressing? And there is also a debate if we conduct advanced care planning is too early. Maybe the person is not ready, and the healthcare professionals may be worried that this may take away patients and their family members' hope. And if we conduct advanced care planning too late, maybe it's too late to have effective and useful conversation with the patients. Maybe the patients already don't have enough capacity to have such conversation. So advanced care planning conversation is not that effective. So under the ACTION trial, we asked the patients, the participants of ACTION trial this question: how did you feel about the timing of your advanced care planning conversation during the study in relation to where you find yourself in your life at this moment? And one thing I want to highlight is that all the participants in ACTION trial is a patient with advanced cancer. And the answer to this question are three: too early, just about right, and too late. And we found we had two concepts about timing in the study. One is actual timing. We had data from the medical file of those participants. We summarized the time between the diagnosis of cancer or the time of the current stage of cancer to advanced care planning conversation, and also the time between advanced care planning conversation to their deaths. We compare this with their perception of timing. And here we found that patients who thought the timing was too early, they tend to be more recent diagnosed with their cancer, or more recent diagnosed with current cancer stage. And for those who perceive the timing was too late, when they had the ACP conversation, they tend to have shorter estimated survival time. And in this study, we found that most of the participants, they perceive the timing when they have the advanced care planning conversation is just about right. and this timing is on average is 6 months before their deaths. So here, and this timing is compared to the current evidence. We found that this timing tend to be earlier than normally healthcare providers will often initiate it. And in a previous study conducted in the Netherlands with general practitioner, the timing was 160 days to 111 days. So the timing in action trial is actually earlier than the timing normally general practitioner or healthcare providers would initiate it. So from this study, we suggest that advanced care planning could begin sooner than healthcare providers might typically suggest it. I will give the floor back to Dr. Ida.
Thank you, Ting Ting. Yeah, so some of the people think it's too early, some thought it was too late, but the majority thought it was about right, isn't it?
Yeah.
Yeah. So advanced care planning, it's typically considered a good thing to do, involving people in decisions about care and having them think about it beforehand. But also there are issues with advanced care planning. And in 2021, Sean Morrison and colleagues, they published their opinion paper in the JAMA. And they say that, well, advanced care planning takes away too much from the resources from palliative care, while the results that everybody is hoping for are not generated. So some people have agreed with her, some people have contradicted her findings. But well, I think if we conclude that making sure that the care is aligning what people like, if we agree that that is a relevant thing, so if we say the care that we provide to patients should ideally be like what they would like to have, well, in that case, how can we make sure that we maybe adapt advanced care planning? And so we think the goal is relevant, we want to align care to preferences, but apparently it's not going as well as we hoped for. The concept appeals to many, but what do we need to do differently? So I will go through a number of issues and see how we can address them. It has been argued that advanced care planning may be too burdensome for palliative care. So people who work in palliative care have many things on their plate. Many healthcare professionals have a heavy task load. And doing advanced care planning on top of it might be too burdensome for them. And it could be maybe a solution to, well, have online programs to take the first steps. It might be a solution. And in this way, by having the first steps done online, patients, relatives, citizens, outside healthcare setting might start thinking about their preferences and might start discussing it. So we have a Dutch site that's shown for you on the left side. It was developed at our department. You see Doris van der Snissen, PhD student who wrote her PhD thesis about it. But also sites in the US, such as Prepare for Your Care, are used really often. Another issue with advanced care planning relates to that people may not be ready. They may not be ready to talk about death and dying. Like Ting Ting said, healthcare providers and also families are sometimes afraid to take away hope when they bring up the topic of death and dying. So I would like to share another conversation I had with my mom. And we were, yeah, she was still living at home. At the moment, she doesn't live at home anymore. She was still living at home, and I tried to persuade her that she should have some extra care. And then, after a lengthy discussion about it, she said, when someone grows old, take care of that person, but accept that he will die. And then she said, um, you can place 10 persons around me. I will die anyway. With a king, you can place 50 people around him. Still, so far, all kings have died. All kings who lived 300 or 500 years ago are now dead. So, uh, a wise word, I think. We have to accept that people will die. It is happening, so why should we ignore it? And I more and more think that advanced care planning is about being aware and taking responsibility to become aware of your own preferences, but also become aware of preferences of those of others, people around you. These could be your family members, they could be your friends or your patients. And if you can organize such an awareness in a like official advanced care planning conversation with a trained facilitator, that's very good. But when it's not possible in such a way, for instance, because there is no such facilitator or because maybe a patient is not all the time able to express their preferences, we need to adapt to it. So maybe we can conduct advanced care planning in bits and pieces, and we could be open to people expressing their preferences. So, for instance, if someone brings up a simple remark like, I want to be buried there and there, or whatever it could be open to it and uh, ask maybe what they mean, ask maybe for an example. And it could occur, and it doesn't have to be a long time, but it can occur just in the daily living situation. So, about these conversations, I would like now to share some of the findings of the iLive study, the iLive project. In this picture, you see Agnes van der Heijden. She's a professor of medical decision making at the end of life at our department. And in another European project that she chaired, we discussed and we studied the concerns and expectations of people in the last phase of life. So in this map, you see Europe, countries with a star, they are participated in the study. So these are Iceland, Norway, Sweden, United Kingdom, the Netherlands, Germany, Swiss, Austria, Slovenia, and Spain. And also not in Europe, New Zealand, Australia, and Argentina participated. And one of the things we addressed in this project is the question, do people wish that death and dying are more openly discussed in their society? So we asked over 1,200 people in these 11 countries to respond to the statement, I wish death was discussed more openly in my society. So now I would like to ask you, just take a few moments to ask yourself, what do you think? How many people answered yes to this question? How many people said, yes, I wish that death and dying were more openly discussed in my society? And I don't know, maybe you are alone behind your computer, maybe you are with others, maybe you can share your estimation with someone near you. And then I will share our finding. And I look forward to hearing from you afterwards whether you thought it was higher or lower than you anticipated. So I will now share our findings. We found that overall, over 70% of people indicated a wish death and dying were more openly discussed in their society. So these were all people with a limited life expectancy. The percentages differ a bit per country. The lowest is Slovenia, but still over there it's over 50%. Highest is New Zealand with over 90%. So I just, we can discuss it later. Did you think less than 70%? Maybe I wondered whether people could raise their hands, but maybe that's not possible, but we can discuss later. Did you think less than 70%? Or did you think more than 70%? I guess we can discuss later. So this relates to that concept of timing and what is the right moment. And I would like to point your attention to one of the papers on the action study, and it is about being ready and not being ready at the same time. So this is a qualitative study in which people were interviewed about whether they would like to participate in advanced care planning, yes or no. And some people were ready, but not ready at the same time. So maybe it's not necessary to wait till someone is completely ready. Another issue is the third one. Maybe it is too much to discuss everything between quotes. So everything, everything that is important, all wishes, all preferences, all considerations, it might be overwhelming, and maybe that's too much to ask of people, of patients, of relatives, of healthcare professionals. So if these discussions are normalized, discussing everything at one point, fixed point in time, may not be necessary. Also, if someone develops, for instance, dementia, it might be too much. Their capacity may differ from day to day, and maybe planning conversations a long time beforehand is not the best idea. It might be not completely meaningful because someone might not be in the best circumstances to have that conversation if you plan it a long time beforehand. And maybe we will just have to grab the occasion when it occurs. So listening to people, spending time together, being curious, asking questions, and don't kill the conversation when someone brings up death or dying. I once had a focus group with older people in the Netherlands. So they lived in a care home. They were all aged, most of them way above 80, and 80 years old, mostly near 90 years of age. And some of them said, when I bring up that I will die, my children say, don't be silly, you will live to be 100. And they thought, yeah, the intention of my children is to cheer me up that I will have a long life ahead of me, but I don't feel taken seriously if they don't want to have a conversation with me. So another issue with advanced care planning may be that we focus too much at the individual, and especially in the earliest definition that we have, focusing at the individual. What does this individual want? What is important for him or her? While many people wish to share their preferences and make a plan together with their relatives and the ones near them. So maybe we need to rethink the focus at the individual. And studies, yes, indeed, this is the thing you see in this slide. And studies in the international context show that the focus on the individual might require rethinking. And many patients want to align their preferences with the ones with the preferences of their close ones. And we found that in studies conducted in Asia, but also in our action study, we had qualitative interviews, and people indicated a preference to have their family members more involved. final issue that may occur with advanced care planning is that maybe it's too much about a hypothetical future. So what would you like in the case that something happens? But maybe we shouldn't talk too much about a distant future, but also broaden it to current care discussions and normalize the conversation. So what are next steps we could do? I think advanced care planning is an important concept, but actually it would be ideal, in my view, if it was no longer necessary. So no need of a separate advanced care planning, but that talking about death, life, and preference for treatment are happening and normalized and take place in daily situation of daily living or daily care. And some circumstances will support this change. But for instance, shared decision making is included in clinical guidelines more and more often, and shared decision making requires a discussion of the preferences that patients have. And discussing preferences will become more usual, more routine, and that will also include that people will become more aware of the preferences of their patients. Also, healthcare is under severe pressure in many parts of the world. This is a picture of Corona time, but also nowadays, if we want to, still there is a situation in many countries that we are limited by a shortage of healthcare staff, and care will be limited. We cannot do everything that we want, so that we have to make choices. And that requires that we talk about it, that we acknowledge this situation, and that we discuss what care is best to provide. So another consequence and next step is that it may be better to have the discussions in another setting, for instance, in community settings. And therefore, I give the word to Tintin.
I will continue sharing the study I conducted in the Chinese community in the Netherlands about their advanced care planning conversation. We used the board game to have advanced care planning conversation with those older Chinese immigrants. And this is a mixed method study. I want to start again with the elements of advanced care planning conversation. And we also use this concept in our study. When we talk about advanced care planning, and the first step is to reflect on individuals' current health condition to see whether they have a good understanding or whether they want to have a good understanding about their health condition. And the second step is to think about the future. Just like Dr. Kufaher just said, it's a hypothetical future. It's in a broad way. It's not only refers to time or just a very specific medical care treatment, but also in the situation, their situation in that future. So people can think about how many days or years they have to live if they have to live in a not very ideal situation, what treatment they might take, and if they cannot function very ideally, if they going to need someone to take care of them, to live with them 24/7, how they will imagine themselves in that kind of future. And those kind of reflection is important and it's valuable for them to think and also to prepare to planning for that future. And the next step is to find out their values and goals. It's a very difficult part for a lot of people. And it's also normally it's difficult to just ask people what their values and goals are, as their values and goals is a concrete generic concept. Instead, we ask a bunch of related questions, like give a little bit future scenarios, like what situation would you accept more? No pain, but unconscious, or conscious but waist pain? Like those types of conversation and those types of options, they are not, both of them, they are not very ideal. But people will start thinking about their values, and because those questions ask them to start weight things, which things is more important for them. And the next step is to have conversations about all those topics with their important ones and also with healthcare providers. And the advanced care planning is practiced differently across cultural contexts. For example, in low context cultures, for example, in the in the Netherlands or in the North America, conversations tend to happen in an explicit and direct way. And this is also demonstrated in advanced care planning conversation. It's largely rooted in Western mainstream bioethics, which includes patient autonomy or truth-telling or control over dying is appreciated. But for example, in a different kind of cultural context, for example, in China or in Indonesia, such a high context culture, conversation tend to happen in implicit and indirect ways. So sometimes openly discuss taboo topics, for example, serious illness and death and dying, is not always appreciated, and it's also considered as taboo. And those avoidance is also close tied to cultural emphasis, for example, on social harmony, the idea that we want to maintain positive relationships and also to avoid conflict within the group. And those concepts are more importantly than patient autonomy or individual concerns. And also medical paternalism also can cause the power difference between healthcare providers and also the patient. So those types of power difference can also affect the process of conversation and also the decision making. So how can we make advanced care planning conversation more attractive and make people more comfortable to discuss for people from different cultural contexts, particularly for people from high context cultures, for example, people from China and people from Indonesia? I want to bring up a concept. It's you probably also already know or even used in your study, those advanced care planning games. And using a game, it's a strategy, also a useful strategy to overcome some barriers to approaching some sensitive topics, like advanced care planning conversation. And there are now two games that have been widely used in North America to support advanced care planning conversation, the Hello game and also the Go Wish game. They also have multiple different language versions. And the Hello game use questions and to encourage people to reflect on and to share their thoughts with other people. And the Go Wish card, they also include, for example, statement card that list wishes and priorities about end of life care. And participants will be asked to sort those cards into 3 or more decks according to how they perceive it's important to them, and to discuss those questions and to discuss those statements with other players to discuss why this is important for them and how they want their family members and their loved ones can help them to fulfill their wishes. And this board game is the 5 flavors in a grocery store. This is also the board game we used in the study. And the concept and the name of the board game is actually inspired by a very old Chinese saying that every life have its sweet and bitterness experience. I guess this such concept applies across cultures because in the movie, Forrest Gump also said a similar thing with the chocolate box metaphor. This board game has 60 cards with questions representing 5 different topics related to advanced care planning. There are 4 tokens, so it's designed for 2 to 4 players. It's a very simple game. When the game starts, players take turns in rolling the dice and moving their token along the route. You can also see in the game board, and the player is invited to draw a card of the color corresponding to the circle where their token landed. There are also many sum up cards. It's an appreciation for players. When they answer the questions, the players can also choose to skip or not answer the questions if they don't want to answer. In that way, they don't get the sum up cards. And to add a bit competitive vibe to this board game, at the end of the game, players will vote to select the most actively participated players in the conversation, and who will be rewarded with 2 extra sum up cards. And the players with the most sum up cards in the end of game wins. Here we'll give you more detailed introduction about the question under different topics of the question card. For example, from left to right, we have sweet, sour, salty, bitter, and spicy. For sweet card, it's funny and easy games. We ask questions like, what makes a good day for you? And for the sour card, we ask the past experience related questions. For example, if you could turn back time, is there anything you wish you could redo? For the salty card, we ask questions related with views towards death and dying. For example, there are questions like, who do you think would have the most hardest time accepting your death? And the bitter cards, there are end-of-life care preference-related questions, like when you think of your future healthcare condition, what would concerns you the most? And the last is spicy card. This is also a bit knowledge-related questions. For example, we ask, can family members overrule a patient's previous medical decisions? Those are our questions, but they don't really have right or wrong answer. The aim is to encourage people to have discussions with other players. And in this study, we have 2 research aims. The first one is to identify the key topics among Chinese immigrants during the game sessions. And the second one, it's a mixed method study. We also have quantitative part is to measure participants' self-efficacy and readiness for advanced care planning before and after the board game session. The methods, it's a focus group part. The qualitative part is the focus group study based on in the form of a game session. We use a question card of the board game as the question list of the focus group discussions. And we also have quantitative part is the pre-post test, where the participants were invited to fill out some questionnaires. In the pre-test, we have demographic questionnaire and also the self-efficacy and readiness sub-scale. And at the end, in the post-test, we asked the participant to fill out the self-efficacy and readiness subscale again. And they also invited to fill out their satisfaction and also their experience with the game sessions. You probably will ask where and how those game sessions happened, what those settings looks like. We conduct our study in Chinese community organizations. There are multiple types of Chinese community organizations in the Netherlands. For example, there are community center, they have a non-profit organization. Their ambition is to deliver care or bridge gaps between Chinese community to Dutch society. They also have Chinese daycare center and also nursing homes. We use such a community-based approach to reach to our participants. We start from those community organizations and also through the social network of those, we call them community leaders. They are well respected. They also worked in those community organizations. They more oftentimes they are leaders of worships, for example, the priest, or they are managers of worked in those organizations. We use through their social networks to reach to more our participants. The inclusion criteria and exclusion criteria in our study. We include participants who identify themselves as Chinese. They speak and they can understand either Mandarin or Cantonese. For the older adults, they're aged over 60 years old. And we also invite the relatives of older adults. The inclusion criteria for them is they need to older than 18 years old and they have to be unpaid caregivers. At the end of the study, when the data qualitative data reached to saturation, we had the 12 focus groups. And within those 12 focus groups, we have 3 groups in Cantonese with Cantonese speaking facilitator. We have 7 groups who hold in Chinese church. We have 2, we call them family game sessions. Those 2 game sessions, we conducted the game with the older adults and also with their loved ones, their spouse and also their older children. And the duration of the game sessions ranged from 45 to 80 to 95 minutes. We had 43 participants, in which there are 39 are older adults. We also have 4 relatives. Most of them, they're female. Most of them, they have fair or good health conditions. They live alone or live with their spouse. And also most of them, they have religious beliefs and struggling with communicating in Dutch. Here you can also see their experience with the board game. But the majority of the participants, they found it's interesting, the game, and they are satisfied with the questions we asked or they encountered during the game sessions. We also analyzed the pre-post test. We found that even though there is no statistically significant increase after the board game in readiness and self-efficacy after the game session, but we can see those number increase in their scores, both in self-efficacy and readiness. So we can see that the board game session, they have the potential to increase self-efficacy and readiness among these groups. And for the qualitative findings, we have three main themes. They are prepared for future health decline and control, and also burden. I will give more detailed introduction in the following slides. The keywords of the first theme is future, and it also provides insights of how Chinese older people perceive future and also their perspectives preparing for it. Some of them, they think it's not relevant. They're reluctant to think about future health decline. They think now it's not their main priority. Life is very comfortable now. They want to postpone it, to wait a bit, to facing the matters of aging, illness, and death. There are also some of the participants, they have intention to create meaning in the afterlife. They also already have the conversation with their family members, not about a specific treatment, but in a very broad idea. One participant said, if I passed away in the hospital, they want to tell the son that they want to do the organ donation. The second thing is the sense of control over the future. Here we can also see that their past life experience of interacting with the external system, with their family members, it's a very important resources of their sense of control over the future. For example, if they already had conversation with their family, and they get very positive response from their family members. They get more reassurance about their future. They have the sense of control. One participant said, my children will listen to my wishes. They said, we will do whatever you want. We will do according to your wishes. But there are also some participants, they don't have such sense of control because partly because their previous experience. They said, I want to die in the hospital, but the hospital won't admit you. They will just send you away. You feel powerless and cannot make your decisions. And in the third thing, it's it's a very big theme in our study. Most of the participants, they more or less mentioned such concept. They worried that they were becoming a burden in their future. For instance, they concerned that they will burden their children or their families with making difficult decisions. They will burden the family. They also want to avoid potential conflicts. And they also think the longer they remain unable to care for themselves, the heavier the burden on their loved ones. So some of them want to hasten the death. And even some of the participants, they feel that visiting the graveyard this also can be a burden for their future. So like one of the participants, they said, they want to do the cremation and scatter the ashes anywhere so their children don't feel the need to go back and visit the graves. But we also have different ways to interpret the burden. When the role switches between the caregivers and also the recipient of the care, the idea or the interpretations of becoming a burden can also switch. For example, when one older adult think how they act as a caregiver, they said it's an opportunity for a family to come together. Perhaps we can talk when we meet and remember the family members. I think it's a meaning in this such a process. So in this study, we found that preparing for the future, sense of control, and also becoming a burden, those are very important aspects among Chinese immigrants. So we also suggest healthcare providers, those are important things also to consider when having such conversations with patients or with participants with Chinese cultural background. And 5 flavors in your grocery store, it's a well-received tool to engaging older Chinese immigrants. I can also imagine using such concepts, food, culture, and also using flavors. This can be a very important and also maybe an interesting way to engaging people for those who comes from cultural background that food is a very important means of communication and expressing love. And playing a game in a community setting, this way, it's a feasible way to introducing the concept of advanced care planning in the community, maybe not only in Chinese immigrant community, but also in a bigger, broader immigrant community or other kinds of underserved communities. Yeah, I will give the floor back to Ida.
Thank you, Ting Ting. We are almost at the end of our lecture, and then we will are open to answering questions. I think some of them popped up in the chat. I want to end with a quote of my mom, and referring to her death. My mother said the other day, "The time will come one day." Poppetje, that's the name she uses for me. And for me, it would be good if you were with me. You don't have to come with me. You just call for your husband. Or I will come. And she was laughing. And she said, Renee, come to Ida. She doesn't want to be alone when I'm gone. But it will come one day. And I think in this way, she is also helping me, in a sense, to become used to that idea that one day she will no longer be here. And I would like to end with a recommendation to all of you, not waving off the conversations about death and dying if people want to bring up that subject. So thank you so much, and looking forward to discussing this further.
Thanks so much for the nice presentation and very clear presentation to us. Thank you, Dr. Ida, and also Ting Ting. And now we will have a discussion time, and maybe we still have 1 hour, maybe, or not, or a half hour. What do you think?
Yeah, we talked for a long time.
Oh, okay. So we have we have maybe 1 hour to discuss about your presentation. Maybe. Okay.
Not an hour, I think.
It's been at 10:30, I thought.
Yeah. Well, do you think we have another hour, Judy? I'm not sure. I have another meeting at 11.
Oh, okay. So
maybe half an hour or so.
Half hour is enough.
Yeah.
Thank you very much. So we have some question. Maybe you can check in the chat, Dr. Ida, maybe Ting Ting. You will see several questions on that, and maybe you can answer it one by one.
Yeah.
Yes.
Yeah. There is one. It says more openly in their society, a clear majority. Yeah, that's Siti Nafa said, yeah, a clear majority. That's, yeah, I think I agree. Then there is a question, Professor Ida, which is better for the elderly, end of life care in a nursing home or living with their family? Well, I think it depends very much. So living with the family, it's not always possible. for a number of reasons, because people may not have enough time, because they may also need to, for instance, they have a job, go to their job, or to have other responsibilities. Maybe the house is not big enough. Or, for instance, my mother, she now lives in a small care home. Yeah, she needs different circumstances to a large bathroom, a space to be driving in a wheelchair. Also, her day and night rhythm was changing, so she was awake in the night really often. And then, if you also have to do things in the daytime, it's really difficult. So, I think if it's possible, maybe many elderly people want to stay with their family, but at one point, it's also good if there is professional care available. Another one, how can technology help us reach out earlier to patients who need palliative care, so that care is more planned and meaningful? Well, yeah, all the questions I appreciate much. I think technology can, for instance, help. So there are online programs for advanced care planning, and people can use these to think about care and discuss care, also talk about it with their doctor. It can make them more aware of what is possible and maybe what is necessary. And also help them communicate with others what they need. And I think that can help. And also in your project, we are now developing also content for people. Maybe you could share some words about it, Ting Ting.
Yeah, in our new project, we want to develop like knowledge packages for Chinese community. It's aimed to deliver Dutch palliative care related information for them, so they can grasp the interesting information for them. It's also one way to normalize the conversation and also to have such a useful information in the community, so people can approach to such materials when they need it.
Yeah. And technology can also help, like for instance, the group of Chinese immigrants that Ting Ting has worked with, they although they lived in the Netherlands for a long time, sometimes they worked in a setting where they did not need to speak Dutch very much. And although they lived in the Netherlands for a long time, they may still prefer to read in Chinese, for instance. But the technology now allows also translation easily of materials. So we will help people to find the materials that are relevant, and technology can help us now to also translate to other languages really quickly and make more resources available for people. Maybe next question, Professor Ida. There are many Indonesians who have lived in the Netherlands since birth and are now elderly. Has their culture become more open about future choices? Well, very good question. And yeah, I'm not sure about specifically that it's indeed true. Many Indonesians who have lived in the Netherlands for a long time, and I think living in another country will change. It depends also on your acculturation. And it reminds me of the study and the review that you did, Ting Ting, about acculturation and advanced care planning among Chinese people living in other countries. Could you maybe share a bit?
Yeah, it's true. Like people lived in, so they have the influence from two different kind of culture. One is from the original culture, and one is from the country or the society they currently living. And but it's also may be useful to mention that we also found acculturation among those immigrants. They're a spectrum, so people can integrated the society from very little to a lot. So their perspectives and whether they identify themselves more towards to their original culture, or they identify themselves more towards the culture from their host country. And they might also have a different interpretation because of the impact from the culture of their host country. They also can have different interpretation of all the values, and also with all the culture concept from their original culture. So yeah, there can be a very huge diversity among such immigrant groups. So it's hard to just conclude that they will definitely become more open about culture, about future choice.
Yeah, thank you. Yeah. Then the next question, Professor Ida, in practice, we often find that families may disagree with the patient's preferences stated in the advanced care planning. What is the best approach for healthcare professionals to handle such conflicts while still respecting the patient's autonomy? Yeah, so this is indeed, yeah, it's a very good question, and also pointing at a difficult thing. And the person says, Christine, she says it is stated in the advanced care planning, so maybe referring to like a document in which a patient said what their preferences are, and then the family is not agreeing with it. So yeah, there is no easy solution, but I think discussing uh, um, discussing while the person with the person may be a good approach. Not only relying on what has been documented, because that might be very difficult. Um, and yeah, there is no easy solution to it. And I think a change what has happened over the years, that earlier documentation was aimed at very detailed, I want this the treatment in this and this situation, and then it's very detailed and clear what someone wants, but it's focusing more towards what is the goal of your preferences. So, would you like to live as long as possible? Or would you, so if it's more goal oriented to know the preferences, it might be easier to discuss. It's not that black and white, maybe. I realize it's a bit vague, but that's my idea. I don't know. Would you like to add anything?
Yeah, it's also interested me with what you put in the chat, like stated in the ACP. It's also, I think it's also in the paper, What is Wrong with Advanced Care Planning. The author also often mentioned that it is very difficult for a doctor to really do or proceed the treatments according to what patients stated in the advanced care planning document maybe years ago or maybe months ago.
Mhm.
It's difficult. So I think one would help is to have multiple conversation along the time, so the patient can have opportunity also to reflect on it multiple times. And also, I think also now from all a lot of literature, we can also see that patients or older people, they often found including the families together in the conversation also help them and give them more power to also join the conversation. So yeah, it's really also depends on whether patients want to have such joint conversation, but a shared conversation also to improve shared understanding of each other maybe can also helpful for healthcare professionals to handle such conflict.
Yeah, thank you. Yeah. Then the final question is about how do technology, data visualization, and artificial intelligence fit into interdisciplinary public health research in the Netherlands? Could similar tools be implemented effectively in Indonesia's context? Yeah, I think that you may refer to the research we are conducting, the 4D picture study. And in this study, we indeed have data visualization and technology and also AI. In a study, it is focused on treatment for people with cancer. And yeah, I think some of the tools could be implemented also in Indonesian context. For instance, there is a tool called metro mapping. There is a website about it. You could look it up. And it consists of visualizing the care path. It's not aimed at patients, it's aimed at healthcare providers and making very clear what the care path looks like and in which points decisions are made. So when is it, for instance, an option choosing between radiotherapy or chemotherapy? So this is not as much public health, it's also clinical care. So you could maybe look it up, the metro mapping that I think is applicable in many countries. That's just the first response. Would you like to add, Ting Ting?
Yeah, I think the technology definitely helps, especially, for example, the artificial intelligence. I think one part of ACP is to have such a future hypothesis. So artificial intelligence maybe also can help with that to deliver a hypothetical future settings, so the participant can have more vivid idea about what the future care may means or may look like.
Mm-hmm.
Yeah.
Yeah, thank you.
There is no any other question in the chat, but I want to ask to Ting Ting. Can I?
Yeah, sure.
Okay, I think it's very nice methodology in research because you use like a game to collect data, something like that. So I was wondering about how you can do data validation of that, because maybe data validation, because you collect everything, the perspective, the answer about the crew kuka from your game, and they will give their opinion. But maybe because you know that in the qualitative method, we must also validate the data. That is the first question, and the second question is about when you did it. So you don't use like a research assistant. You did it by yourself. You don't need about the research assistant, because I see in the picture I only see you and maybe several people as your informant. Maybe you can explain about this. Thank you, Ding Ding.
Yeah, maybe I will. Can you repeat the first question?
About data validation. So data validation.
Data citation?
Yes,
Saturation?
data validation.
Validation?
Validation.
Yes.
I think one Yeah, it's important approach in qualitative study to have such methods or process of data validation. I think we did it with through reflection among authors. So I have another reviewer, also another author. She's the second author. She's also a researcher trained in design, in qualitative study, and also in healthcare related research. So we analyze the data together, and also uh, uh, to have a multiple process of comparing the original code to the same we developed. So we did this data validation through reflection among authors. And for your second question, yeah, the photo it's a limited photo, so I choose a few. I also have another facilitator. She also helped me with the groups in Cantonese because I myself I can only speak Mandarin, uh, understand a little bit Cantonese, but it's difficult for me to facilitate a Cantonese game sessions. So I also have Cantonese a facilitator. She helped me with those groups with Cantonese speaker in the game study in the game sessions.
Okay, thank you very much. And the one question again, because I was wondering about what the big challenge when you did this method to collect the data, because you use a game. But usually we can use a focus group discussion to explore about their opinion, but you use the game to get some opinion from the people. So I want to know about what the biggest challenge in this method.
It's I think the big difference between you have a standard or structured focus group compared with you have game sessions. If you conduct a focus group, you have a structured game list. You can go through your list, but and everyone will get the same questions within your groups. But for the game sessions, as I mentioned, we have 60 question cards. So within each groups, we discuss the different questions in those groups. But every groups we covered the same topics. So I think that's one of the difference between focus group and have game sessions. And challenges, I would say it's game sessions, so people are more relaxed. It's also advantage of have game sessions, but it can happen that people may go too far from one questions, maybe too far from maybe still related with the study to not very much related the study. So you need to kind of put them back to the topic.
Stick to the topic.
Yeah.
Yeah.
So do you think that when you use in the game session, so the participant more open to express their opinion, then we use the commonly focus group discussion?
Mm, I think it's difficult to compare like this, but uh, uh, I think it's helpful to have such game sessions to discuss those topics. And it's also helpful to have those game sessions in a setting that they are familiar with and also with people they are familiar with. Because we conduct those game sessions in all the community organizations. And so the players are also from the community organizations. So oftentimes they also know other players. So this is also helpful that they discuss this, they play this game with familiar person in a familiar setting.
So I think it's a strong point that you have. Yeah, the network of Ting Ting is a strong point to make the study work. So you have connections with the people who are leaders in the community, and therefore this is possible. Also because you speak Mandarin, it would be, I think, very different. Maybe impossible for someone without that background. Yeah.
Okay. And
But could I ask you, Dr. Judy, what do you think about this approach? Is it a feasible way, do you think, in Indonesia? And I don't know what the other participants think. Can you imagine having such a game?
yes, because you know that we only know about the conventional qualitative methods like focus group discussion, in-depth interview, something like that, to collect data from the informant when we use a qualitative approach. But maybe in this session you introduce a new method to collect the data with a game session. That is very interesting, and maybe we can implement it in when we do the same thing when we want to explore about the deep opinion from the informant. That's very nice, Dr. Ida. But actually, I want to ask to you, Dr. Ida, because I'm still curious about this. So, do you think that this method can be accepted as the scientific collection data method? Do you
Yeah.
think or not?
Yeah, so there are two things about it. So one thing is the game is a way to have discussions about sensitive topics. That's and it could also be used outside research. So communities could use it to have conversations among their members without a researcher being there. So this is a way. So that's one thing. It is a way to initiate discussions with maybe a bit lighter touch and a game element to make it more accessible and less heavy. That's one thing. And then in addition, we are now doing a study to see whether it works. Therefore, like Ting Ting said, we ask people to complete a questionnaire. It is a questionnaire about advanced care planning, a validated questionnaire developed by Rebecca Sudori. She also initiated the Prepare for Your Care website. She's a very well-known researcher in the field of advanced care planning, also a medical doctor. So there is a questionnaire about are people ready to discuss death and dying? And the participants in the game sessions, they complete the questionnaire before the session and after the session. So that's part of our research. And you also have a discussion with the people. That's the research. So we have a game. That's a way of bringing up the topic. And apart from it, we have the research. And I think that's a really acceptable, thought through, innovative as well method.
Yes, yes, okay. It's very nice because we can introduce a new method when we want to elaborate more about the topic.
Yeah. I think having conversations is important and also in a way that fits with the people. It's no use to say, hello, and I'm going to talk about it, whether you like it or not. No, we have to find a way that fits with people so that it is good for everybody who participates. And so maybe having a Bahasa Indonesian version of the game would work.
Yes.
Maybe different taste, 5 flavors. I don't know. I think 5 flavors is a concept in the Chinese kitchen, isn't it? Maybe another phrase for Bahasa Indonesia. But
So for the all participant, if you if you have any questions, so please you can unmute your microphone, you can raise hand, or maybe you can text in the chat. So please don't be hesitant and Dr. Ida and Austin will ask for your question.
Yeah. I think we have 5 more minutes. Five
Yes,
more
5
minutes.
more.
Then,
Yes,
yeah, then we have to go to the other meetings. Yeah.
Any other question for the participant? Or not? Or you think that is enough for us? Okay. I think there is no any question again. There's no question, Dr. Ida and also Ting Ting. It's very nice and also very nice discussion. And thanks so much because you can give a new perspective when we want to do a qualitative method to elaborate about the data with the qualitative research. We can use the same thing when the same as the Ting Ting Zoo did it.
Yep.
So it's very nice. Thank you, Ting Ting. And maybe if you want to maybe make Indonesian version, you can make a collaboration with us, with me, with all my students also.
We make what? Sorry?
With all my students, because we have many students in doctoral program, so maybe they have maybe some idea about the qualitative research method, so we can make any collaboration on that.
Yeah, and you can share with us. You know how to reach us, Yuri. And we are also, if you like, we can share the presentation. We will make a PDF.
Yeah.
For so to share with the students, but we will make a PDF version of our PowerPoint.
Yes. So I think this is in the end of the session. Thank you so much again, Dr. Ida, also Ting Ting, for your sharing. It's very nice and also new insight for us. But before we end this session, so we will make a picture. So would you like to
make a picture? Sure. We will have then the.
I will change it to the. Yes. Okay. So for everyone, please you open the camera and give best your smile to us, and we will make a picture in several sessions. Mas Nanang sudah ready, Mas Nanang?
Ready.
Okay. So in the count of the 3, we will make a picture. 1, 2, 3. Okay, thank you. We move to the next frame. Okay, 1, 2, 3.
One more.
Okay, and the last frame. 1. Okay.
Nice, the hearts.
Okay, thank you so much, Dr.
Thank you.
Ida.
Thank you so much.
Thank you.
Bye-bye. Wishing you a good meeting.
So we will end this season and we will meet again in the next season. Thank you so much. Good
Thank
morning,
you. Bye-bye.
Dr. Ida, and good afternoon for everyone. Thank you. Bye-bye.
Bye-bye.